I request Dr. Nirmal to talk about a burning topic, way out to cashless capping in ophthalmic practice.
Thank you. Thank you, sir. And after that wonderful talk on one crucial issue of medico-legal importance, this is another burning problem among the practitioners. So cashless everywhere. So what are the challenges and how we can go forward? Is the audio connected?
Let's go.
Please adjust the audio, please.
Can you connect the audio? Audio?
Thank you.
Right. How many of you are doing cashless here?
Why are there laws?
Okay.
What are laws for? Anyone?
Social order.
Just watch this video carefully. It runs for a
To
minute
protect
or so.
the person's personal rights.
So that you can rely on the government?
Justice? Thank you. Tell me, was I unfair to your classmate just now? Indeed I was. So, why didn't any of you protest? Why didn't any of you try and stop me? Why didn't you want to prevent this injustice? You see, what you have just learnt, you wouldn't have understood in 1,000 hours of lectures unless you lived it. You didn't say anything because you weren't affected yourself. And this attitude speaks against you and against life. You think it doesn't concern you, so it's none of your business. Well, I'm here to say, if you don't help bring about justice, then one day you too may experience injustice, and there will be nobody there to stand before you. Truth and justice lives through us all, and we must fight for it. Because in life and work, I mean, we often live next to each other, but not with each other. We console ourselves that the problems of others are nothing to do with us, none of our business. And we go home glad at night that we're spared, but it's about standing up for each other. Every day an injustice happens in business, sport, or on the tram. Relying on someone else to take care of it is not good enough. It is our duty to be there for others, to speak up for others when they cannot. I am here to teach you the power of your voice. I want you to learn to empower you to stand up for what is right, even
So basically this issue about this injustice being done in the name of cashless. Right? So when the issue came up, many of our friends remained silent. So it started affecting the majority of them. And over a period of time, now it has come to this situation where it is going to affect everybody, irrespective of whether you do cashless or not. So the same situation that were faced by the girl who was sent out of the class without any question. So this is the basic of issue. When majority of us remained silent, it was deafening silent when it was imposed only on the providers, particularly private providers. The NGOs felt that they were too big. The medical colleges felt that they are not part of this community which they are serving. The corporates thought they were powerful, they can lobby and get things done. But now, after this cashless everywhere, everyone started pinching, everyone started scared. And now there is deafening silence because nobody knows how to talk. So this is basically the present status of health insurance. And there are so many stakeholders, and instead of we being the center of the health insurance industry, or patient being the center, we are now relegated to the last status. And there are so many other stakeholders taking the lead. So this is a complex situation. So instead of doctors and patient in direct coordination of care, now it has become indirect coordination of care. There is no coordination. It's only indirect way of treating the patient. Instead of we giving care directly to the patient, it is the insurance that is going to buy the care on behalf of the patient. So you have directly from doctors, we are now gone to the situation where we are care providers, and care providers to the people who the insurance or third party suggests. So there is complexity in this situation, and always complexity leads to confusion. Why there is sudden influx of this power politics in healthcare? Because of the huge market. If you see in 2023, the health market was 0.82 trillion, and in 28, another 4 years, it's going to be 1.36 trillion. So the market is going to be enlarged, and now that there is so much money into the system, everybody wants a big piece of the cake. So health insurance traffic is increasing day by day. That is probably started with COVID, and now it has reached an enormous situation. And this is the numbers in terms of the percentage. From 10%, it is going to be 35% in 2022-3. So I'm not going to discuss about whether insurance is a boon or bane. But the problem with insurance is increasing. Almost 99% of providers have faced problem because of insurance companies and TPAs, and 99% had to answer repeated queries and documents. So this is the time we are supposed to give it to our patients, but we end up answering insurance queries. So what health insurance companies have contributed to the healthcare? So this is a column from a US paper. The health insurance companies are useless, get rid of them. They've been successful at two things. One is making money and getting the public to believe they were essential. So this is what happened post-COVID, and the complexity increase. The moment complexity increase, the healthcare cost increase. The administrative cost from 5% it has rose to 18%, which means that we are spending 1/20th of our money to get the insurance money. That's actually our money that is supposed to come to the healthcare providers, and now this insurance industry is going at our cost. So what we call them is, what we call others who grow at others' cost, we call them parasites, or in surgeons' language as tumors. So these tumors have to be excised once for all, because they doesn't add to the safety or value to the healthcare system. So insurance is not addressing the fundamental problems of healthcare. Neither the cost, choice for the patients, access have not been improved, and the quality. This is our worry. The quality has not increased, but the cost is going up, and the providers are not getting their due. So everyone is affected, the uninsured, the underinsured, and insecurely insured. So it's an unhealthy sign, because in Kerala and in southern part of Tamil Nadu or southern India, 200 smaller and medium hospitals closed in Andhra. Smaller hospitals keep vanishing in Kerala. We have the data of Nursing Home Board of Kerala as well as Tamil Nadu. There are many places hospitals are for sale or lease, and there are quite a number of hospitals, particularly among the eye care centers, lot of acquisition by corporates and chains. This basically, it's an unhealthy sign not only for entrepreneurship but also for corporate India, because the ease of business, doing business is affected. So what is the background of current situation? Basically, the universal health coverage, which is a political issue and government schemes, has now been taken over by the private insurance companies with the help of technology and in the name of digital health, and all these being done by non-health players. So this is where problem started. This is the background of current situation. From PSU companies to private insurance companies, the moment private players came in large numbers and invested that money, they wanted a lion's share of the healthcare market, and this is where the problem started and cashless everywhere came. So this is a nice table to see who's exactly funding this issue. If you see that it is funded by the government, but it's not the government money or the political money, it is funded by the taxpayer money. So which means the money that is supposed to go to the government hospital for infrastructure development is being routed through the insurance companies, and that is 30% added cost. So our money is being given to the insurance companies at a higher cost of 30% to fund the government hospitals in turn. So it's actually our money getting wasted, and this is what the table detects. I will not go into the details, but what happened in the last few years is, because of this, the digital health incentive system, which is supposed to earn incentive up to 4 crore. So this is for the providers who are supposed to go into the digital health system. And blockchain technology, all of you know, technology is being integrated. Now they want all the healthcare providers to take up this and come into their healthcare exchange system, which means like the government buying power from the power exchanges, the government and companies will buy health from the providers like health exchange system. So this blockchain technology is being used for that. So what happened is replicate this Ayushman Bharat to increase the penetration across pan-India, reach the missing middle. The middle class is basically lower middle class and upper middle class who are paying from their pocket to the private providers, and here they are planning to get this missing upper and lower middle class who are essentially paying for the services to get the insurance, and they will pay now. So with power and policy help and with the help of technology, this cashless is being promoted by the General Insurance Council. So why the private health providers have to be worried? Because 1/3 of all hospital is owned by private sector, particularly single doctor or a family run private sector, and 40% of the hospital bed is run by this sector. And in healthcare, it's very difficult to establish beds overnight. So the policy people, for the governing people, face two key challenges: very high capital investment and operating expenses. So when hospitals are already there and it's available at a cheaper cost, they want to take over these 72% of private healthcare enterprises. That is where all this policy are being designed by the corporates, by the governing people, to take care of this share of 72%. So basically, it is a policy issue which is being thrusted on the private players to take over their enterprises at a cheaper cost. And this is the health exchange mechanism. So now this is being pushed to all the healthcare providers to become part of this health exchange, and this is being promoted currently. So what happens? The insurers focuses on 6 critical success factors. So they want to have low claim ratio. That is the reason why in the last 1 year or so, the claim ratio is very, very less. Their large willingness to pay, so they are not unwilling to pay to the providers. That is the reason they want to have capping on everything, and they want to make their profitability, large profitability, so that they can sustain in a better way, and they want to have higher renewal and customer retention ratio. That is why all this portability, everything has come. So this business model is essentially from business to customer model. Now it is business to business environment. So it's very, very difficult for private players to sustain in this. So GIC plan on cashless, is it right? So this is a question asked by many providers. So legally, cashless is, so any state health scheme, whether Ayushman Bharat or the state schemes, are not charity. It is a right under healthcare. So it is a right of the patient as well as the public. And government or any insurance company cannot reject reimbursement claim. So this has been clearly said by Madras High Court in a judgment given in 2019. So this cashless 100% is legally incorrect. We can question that. So why do we should go against this? One is the financial strain. If you accept cashless, it's going to strain the hospital financial stability and impact our cash flow, and also we have to be dependent on insurance companies to maintain this cash flow. So this will again, in the long run, open floodgates to corruption. They might demand money to clear our own money. The second, so for this you have to understand these four costs. Our healthcare cost is based on these 4 C's. So cost have to be monitored. There should be sufficient cash to maintain our payment obligation, that includes salary. There must be capital to buy equipment. If you go to the trade, there is so much money flowing as a capex. And for any business to sustain, we need to control both incoming and outflowing resources. If we understand this, we will not sign this cashless business. And we also need to manage the 5th C, that is the contract management. If you see the contract, it is totally one-sided. It is not at all in favor of the providers. So you have to take this into consideration. The second part is administrative hassles. Across the table, we were getting the money from the patient. But now what happened is, there is administrative cost. We need to employ 2 or 3 insurance administrative person to get our own money. Right? It's the money that we are supposed to get to serve our patients. So in the process, there is a cost component to space requirement, equipment costs, documentation and courier costs, and too many portals. So we have to train our employees for that, and also the security and confidentiality issue. So recently the AIIMS entire website, entire EMR system of AIIMS were hacked. With so much protection, they can't do anything, and they were taken for ransomware. So small hospitals cannot do this, so it is a serious issue. So 4th one is the standard and quality compromise. If they keep on containing the cost, so hospitals has to curtail their quality services. So this will again affect the quality of trained doctors and staff, and this is where all this analysis really helps. The 4th one is it limits complex procedures and innovation. So in the garb of packages, we are strictly made to adhere to lower cost and simple lenses, but our patients want the better quality lenses and the better technology. So it limits innovative medical technology and limit our ability. The 5th one is it affects the patient experience. Cashless system has contributed to longer waiting times, reduced personal attention, and affect overall patient experience. For these 5 reasons, and it also deny the right to care at the right time, like golden hour concept. Most of our surgeries are daycare, so we have to provide service within that 2 or 3 hours. So golden hour concept has to be brought here, like acute care and trauma. So how can we solve the issues? So let me know if I'm exceeding time. 5 minutes more. Okay, so how can we work together as a group of people, as association, as providers? So risk can be managed in 4 ways. The risk transfer. So we can transfer this to aggregators, but again aggregators are going to pinch us. Risk avoidance. So this is the best method, like Bombay doctors did it a few years back, that avoid cashless altogether. Maybe Dr. Muscati can give his experience. So that is the best one, risk avoidance. Risk acceptance, NGOs, government, so if there is additional funding, you can always take the risk and do it. But again, it needs lot of costing as well as funding from the charitable agencies or government or NGOs. So private players cannot look into this issue. So we have to better avoid the risk. And understand costing of your services. Never copy costing from the point of your colleague or neighborhood practitioners. You do your costing procedure and accordingly charge the patients. So think of hospital expenses like a magic show. So transparent costing is very, very important to know how much you are spending for your surgery or procedure or providing consultation. So second, negotiation strategies with insurers. So we are all taught medicine, we are all taught to do surgeries. Unfortunately, negotiation strategies is very, very difficult, particularly with insurance companies. So we have to develop a good negotiation skill. So we have to be rigid to stick to our rates. So for that, we have to understand our costing and then only go to them for discussion. And billing and claim processing. We need to have a proper transparent mechanism for billing as well as following the billing system and tracking the claims. And we also need to diversify non-insurance revenue streams. So there are so many ways of going into this. I will not go into the details. And ask patient to rate. They ask patient to rate the hospitals. Now it is our turn to rate the insurance companies and TPS. So insurance companies are scared about this because their business is based on this, right? So we have to ask our patient to rate the insurance company services, including the TPAs. If we start doing that in a large scale across India, they will come to the negotiation table. So tackling third-party insurance, you need to have a system in place and monitor them. And what next? We have to be united. Don't look at our neighbor as competitor. So let there be uniformity among us. So it's very, very important we decide the cost and tell them this is the lowest possible rate. Beyond this, never negotiate. Work for sustainable healthcare. It's important we stick to this and look forward to working together as association to help our members and also work with all the providers as collaborators. So these are all very important issues. Apart from the empanelment issues, we also need to take care of this. So many systems, licenses, Rohini, and entry-level system. So all these leads to the complexity. So as a association, we need to fight for this. So packages should not be mandatory clause for empanelment. Packages should be based on scientifically worked template. This is our demand, and I think from Ophthalmic, since Dr. Mathur is here, from AIOC side also we need to work for this. To demand, no packages and scientifically worked templates. So this will sustain us in the long run, and also there should be a third-party mechanism to take care of the grievances. If we stick to these three demands, so we can sail through this cashless, and it has to be equal stakeholders relationship, not somebody thrusting their rates on us, thrusting their MOU on us. So it has to be equal stakeholders. So if we understand this, we can also have a common redressal forum and stay behind with our association to face these complexities as well as challenges. Thank you so much.
Thank you, Nirmal. We'll have some discussion time later.